Well, since von Helmholtz invented the ophthalmoscope, we've believed that diabetes is a retinal vascular disease, but now there are some people that are beginning to question that. So our speaker, Raphael Simo, is going to talk on neurodegeneration in diabetic retinopathy.
Okay. Well, first of all, I would like to thank the organizers, and in particular, Professor Ursula Smitter for inviting me to be here to this prestigious Congress, and it's really impressive to be here in this scenario. And in the next minutes, I will try to convince you that neurodegeneration is also an issue in the pathophysiology of diabetic retinopathy. Well, this is my agenda, and as an introduction, let me just to remind you that diabetic complications represent a significant economic burden in our Western health systems, and that diabetic retinopathy remains as the leading cause of new cases of blindness in working-age individuals. In this slide, I have tried to summarize the pathophysiology of diabetic retinopathy, but I think that in this forum is not necessary to remind it. Just to emphasize that from non-proliferative diabetic retinopathy, the disease could go toward two directions. One is towards diabetic macular edema, in which the disruption of the blood retinal barrier is the main important pathological factor. And the other one is towards hypoxia and an imbalance between angiogenic and antiangiogenic factors leading to neovascularization. This route is more frequent in type 2 diabetic patients, and this is more frequent in type 1 diabetic patients, but as you know, both could coexist in the same patient. But the question is, what are we doing now for treating diabetic retinopathy? Well, we are recommending a tight control of glycemia and blood pressure to our patients. But as you know, diabetes is a chronic disease, and it's very difficult to achieve the targets. And we do nothing directly to the eye till very, very advanced stage, in which laser photocoagulation, intravitreal injection of anti-VEGF agents or corticosteroids or vitreoretinal surgery is indicated. As you know, these treatments are expensive, also with side effects, and I insist it's very, very at the end of the treatment. So everybody agreed that we will have to do something early in the treatment. And what is the new concept? The new concept is that before we could be able to detect under the classical ophthalmoscopic examination any abnormality in the microvascular circulation, retinal neurodegeneration does exist. So in other words, neurodegeneration antedates and also could participate in the microcirculatory abnormalities of diabetic retinopathy, or in other words, in fact, diabetic retinopathy at the beginning is a neuropathy and not a microvascular disease. So here you can see an image obtained in our lab of a model, a DBDB mouse, model that reproduces very well what happens in the retina of diabetic patients, and we have published it recently in PLOS ONE. And when we're talking about neurodegeneration, we are talking about two main concepts. One is glial activation or reactive gliosis. In this case, it's not the microglial activation, it's the Muller cell activation, the macroglia. Here you can see this activation that is you can see by using antibodies against glial acidyl protein basic that permits to see in green the aberrant overexpression of glial acidic protein in Muller cells, and also neuronal apoptosis, as you can see here by the tunnel technique, mainly in ganglion cell layers and photoreceptors. Here you can see the strikingly higher DNA fragmentation in DBDB mouse in comparison with a non-diabetic mouse. This is in general, when we talk about retinal neurodegeneration, what we can summarize in these slides. But this concept is not new. and in fact was first introduced by the group of Tom Garner in USA when the team was working in Penn State in Philadelphia. Now Tom Garner has moved to University of Michigan. Here in Europe, there are a lot of investigators, but perhaps I would like to emphasize the work of Hans-Peter Hammes from Germany. Hans-Peter Hammes has seminal papers in vasodilation, but he also emphasized the role of glial activation in the neurodegeneration. And finally, our group, in which we have mainly focused on the loss of natural neuroprotective factors synthesized by the retina as a cause of neurodegeneration in diabetic retinopathy. Let's move to the facts and the gaps. This is the first fact that we published several years ago in Diabetes Care, when we was really impressive when we compare the ACOPs from diabetic donors and non-diabetic donors, matched of course by age and elapsed time from the death, in which we have recorded that the year previous death, there were no abnormalities in the fundoscopic examination. Here you can see that the high rate of apoptosis and also the glial activation that occurs without any change in macrovascular disease. And this was the first step in which we were working more and more on this concept that neurodegeneration is really an early event in the pathogenesis of diabetic retinopathy. More recently, we have found that one of the reasons of this apoptosis of the neurons, of the photoreceptors, ganglion cells, and other neurons of the retina is an imbalance between pro-apoptotic and surveillance signaling. But I have not enough time now to go in detail with this. But the question is how we can measure this in humans, the neurodegeneration. Well, there are two main tools. No? One is the multifocal electroretinogram, which gives us the electric response in different areas of the retina. And the most important parameter that is impaired in diabetic retinopathy is the implicit time, which will be delayed in neurodegeneration induced by diabetic retinopathy. But these systems is some time-consuming and some cumbersome because it needs corneal electrodes. More rapid and more available method is a spectral domain optical coherence tomography, in which it complements very well the other tool, that is multifocal electroretinography, because it gives us not functional but anatomical image, and it's, as you know, and the main parameters in diabetic retinopathy is the reduction in the thickness of ganglion cell layer and fiber nerve layer. There are a lot of papers showing that neurodegeneration precedes microvascular impairment using both either multifocal electroretinography or spectral domain OCT. But the question is whether or not neurodegeneration could anticipate or predict microvascular disease. So the link, the connection between neurodegeneration and microvascular disease. And in my view, these papers are very important, because in these papers it's demonstrated that multifocal electroretinography abnormalities predict which retinal locations will develop microangiopathy in the near future, and I mean in 1 or 3 years. For instance, if this part of multifocal electroretinography is impaired, does mean that in 1 or 3 years, in this part, geographically, in this location, will appear the first or microaneurysm, aneurysm, or heart exudate. I think that is really important, because it's really fascinating that the connection between neurodegeneration and microvascular disease. And what are the mediators or the molecular connection, the mechanisms linking neurodegeneration and microangiopathy? Yes, here we have a review that we have published in Trends in Endocrinology and Metabolism very recently, and we have not enough time to go in depth with it. I will be delighted to discuss with you in the coffee break. But just let me to underline that the accumulation of glutamate in the extracellular space is absolutely essential for neuron death, the so-called excitotoxicity, and also that there are natural factors, neuroprotective factors, synthesized by the retina, which are downregulated in diabetes. For instance, somatostatin, cortistatin, pigment epithelial-derived factor that, apart from anti-angiogenic factor, is a very powerful neuroprotective factor, interstitial retinal binding protein, and another neurotrophins. So the lower of this, the synthesis of these neuroprotective factors in diabetic retinopathy favors neurodegeneration. So this is an important concept that as you can deduce, have also essential therapeutic consequences. And here you have a list of gaps and opportunities. The first gap is that, yes, standardization of multifocal electroretinography and OCT and cost-effective studies are required before their widespread use in the clinical practice. Also, evidence that measurements of neurodegeneration can be used as novel endpoint is needed, and in fact, it's one of the main points of the IME2 program funded by the European Commission, in which we are participating now. Also, a concept and also an opportunity is that in the early stage of diabetic retinopathy, aggressive treatments, for instance, intravitreal injections, are not appropriate, are too much aggressive, and systemic or topical treatments should be developed. Also, that there is insufficient evidence indicated that neuroprotection could prevent the development of microvascular disease, and other had the contrary also. Specific studies aimed at examining the neural repercussion of early vascular impairment are required. And I think that it is an opportunity that it is retinal neurodegeneration assessment could be a very useful model to monitor neurodegenerative disease of the brain. For instance, Alzheimer's disease, as you know, are more prevalent in type 2 diabetic patients. So the concept that the eye as a window of the brain. And finally, the model of streptozotocin-induced diabetes in rodents seems questionable for assessing diabetes-induced neurodegeneration. Why? Because streptozotocin is neurotoxic itself. And then it's very difficult at the early stages of the investigation of the neuroretina to know what is the effect provoked by diabetes and what is the effect provoked by streptozotocin itself. So it's difficult to dissect the neurodegeneration attributed to high blood glucose levels or the streptozotocin. In order to shed light to these issues, we have been involved in several international programs and projects. And in this one, there has been, we used the funds to the characterization, as previously mentioned, the neurodegeneration in DBDB mice. Here you can see the glial activation, the apoptosis, and all these structural changes were associated with typical electroretinography abnormalities. And we have also seen in this model that there is a progressive increase in glutamate levels that, as previously mentioned, is essential for excitotoxicity and neuron death. And this increase is related with a downregulation of GLAST. What is GLAST? GLAST is the main molecule that provokes the clearance of the glutamate of the extracellular space. Thus, the higher the GLAST, the lower glutamate, and so more neuroprotection. So when the GLAST is downregulated, as occurs in diabetic retinopathy, favors the glutamate accumulation, excitotoxicity, and neuronal death. And here you can see how in these DBDB mice there is a downregulation of GLAST induced by diabetes, and also a reduction of glutamine synthetase that also favors the glutamate accumulation. And here you can see very interesting finding that has not already published. That is that when we have a normal angiofluorescence, so there are no hypoxia, there is an increase of VEGF expression at the beginning in the diabetic retinopathy. So we can further discuss about it. So VEGF is not so only, and this could be the link between neurodegeneration and microangiopathy. Well, at this point you can say, well, a DBDB mice is a mice that is a genetic mice that is produced by a mutation of the receptor of the retina and of the leptin, so the receptor of the leptin, and perhaps the changes observed in the retina could be attributed to genetic nature rather than diabetes itself. But this is not true because when we are lowering blood glucose levels in this model, all the abnormalities are prevented. So finally, we have proposed this model as a very useful for experimental testing of the new drugs for diabetic retinopathy. And in fact, we have presented a poster in EASD, European Association for the Study of Diabetes, that was held precisely here in Vienna last September, a poster in which we demonstrate that topical administration of GLP-1 agonist prevents retinal neurodegeneration. As you know, GLP-1 agonists have also a neuroprotective action in the brain. And given that the retina is ontogenically derived from the brain, we postulated this action and it was really observed. The second one is the opportunity, that is that we performed a pilot study in which we are now recruiting the patients in order to demonstrate that retinal neurodegeneration could be a good biomarker for Alzheimer's disease. And we have also created an European consortium for the study of diabetes and accelerator of Alzheimer's disease that we are waiting for the final resolution because, as you know, we will be the final resolution in next week, I think. But to finish, let me only focus on this. That is not a dream, is a reality. That is this project that has been funded by European Commission in the setting of the 7 framework program by 6 million euros, in which for the first time in one of the most important work package, we would like to try to demonstrate whether or not neuroprotection could be useful for the treatment of early stage of diabetic retinopathy. And then is the last point, the therapeutic implications. Here you can see the consortium by ophthalmologists, renowned ophthalmologists in the field of diabetic retinopathy, diabetologists, basic researchers, and also the contribution of IDF Europe as a patients advocacy group. And the primary objective was to assess whether the selected 2 drugs, brimonidine and somatostatin, administered topically are able to prevent or arrest neurodegeneration as well as the development and progression of early stage of diabetic retinopathy. This is a design of the study. Group A was placebo, B another arm, brimonidine, and another somatostatin, both an eye drops 2 times daily. And here you can see the measurements made every 6 months. And the primary outcome was the changes in implicit time assessed by multifocal electroretinography. Why we have used brimonidine and somatostatin? Well, brimonidine because it is used currently in the market for the treatment of glaucoma, and also because there are a lot of papers showing that have a neuroprotective agent. So we can use somatostatin as an active comparator. And somatostatin, by our previous background in which we demonstrated that somatostatin is expressed in human retina, not in amacrine cells mainly, but also mainly in retinal pigment epithelia, as you can see here. and also that there is a decrease of somatostatin production in the retina. As you can see in the vitreous fluid levels of somatostatin, that's significantly lower than in control patients. And also the RNA expression. Here you can see the low synthesis of somatostatin in diabetic patients in comparison with non-diabetic patients. And more important, the lower the somatostatin, the higher neurodegeneration, in this case, glial activation. But at this point, you can answer, well, okay, topical administration, this really enrich the retina when you are using 8 drops of somatostatin? The answer is yes. If not, we have not been funded by European Commission, as you can imagine. This is the proof of concept, the preclinical proof of concept in which we are using a drop of somatostatin, we label it with a fluorochromic green, and in 16 minutes are reaching the retina and accumulating in retinal pigment epithelium. And also not only reaching the retina, but also being effective by reducing electroretinograph abnormalities and histological features, as you can see here, that prevents the oscillatory potentials and vivo wave amplitude, glial activation, and more important, they're reducing the apoptosis very, very clearly, and mainly in the tunnel cells in ganglion cell layer. And is also able to reduce the concentration of glutamate, and this is due for the preservation of GLAST, that is the most important carrier protein that provokes the clearance of the glutamate. And this is the state-of-the-art of the Eurocondor clinical trial. So we are in the first year of follow-up. All the patients have been already recruited, follow-up 1 year, and we will have the first results in January of 2016. And this is my last slide. So the expected impact. So I think that if we could be able to demonstrate that neuroprotection prevent or arrest the development of progression of diabetic retinopathy, we could have impact of clinical management. A new scenario in the treatment of diabetic retinopathy could be open up because we are targeting neurodegeneration, and 8 drops of new neuroprotective agents could emerge. And also, in fact, we are initiating a new concept in the screening of diabetic retinopathy based on checking neurodegeneration. The question is if this could be paid by the healthcare providers or not. And finally, we are targeting prevention, so in some degree we will reduce the economic burden related to diabetes, and we also are triggering innovation and developments in the pharmaceutical industry that is also useful in these times of economic difficulties. That's all. Thank you for your attention.
Do we have any questions? So those penetration studies to the retina, were those in mice or rats, or that showed that the drug was reaching the retina? Was that an animal model? So
the question, sorry, is?
The somatostatin.
Somatostatin.
Yeah, reaching the retina. Was that through the bloodstream, or was that through the cornea, or how does it get there?
It's transscleral route. It's by transscleral route. So we have performed. I have not enough time to explain pharmacokinetic studies, and also in not only in rats, but also in mouse and in rabbits, and it's for transscleral route reaching the retina very, very rapid, and not only by somatostatin, by other small peptides. With somatostatin is very small peptide. It's easy to reach the retina.
Okay.
I'm Mike Abramoff from Iowa. Great presentation. As you know, we're working on this also. I'm excited about the concept of neurodegeneration and being able to prevent that locally in the eye. What we're finding, at least from OCT data in humans and mice, is that it's very tightly narrow progression. It's more like aging, meaning there's not so much difference over 5 years in people who develop DR and non-DR in terms of how much their nerve fiber layer and ganglion cell layer decrease. So I'm still not convinced that you can predict who's going to get vasculopathy from the amount of neurodegeneration. And the other thing is that it seems not only to be limited to the retina, but also to the brain in general. So what we see in the mice, and I agree we use STZ mice, is that it seems to start with the nerve fiber layer, and it may actually be associated with a process in the brain that affects the axons, and only later the ganglion cells in the retina. So then it's hard for me to see how topical agents in the eye would help when it's actually brain-initiated process. I'm not sure either, but I was interested in your comments on this.
No, I agree with you. So I think that I would like to provoke more than you on this question. Of course, that you are absolutely right that perhaps at the end will be a subset of patients with neurodegeneration will be important for the beginning, for the early vascular impairment, and perhaps another will be not important. We will know with the Eurocondor project whether or not what is a subset of patients and to characterize the phenotypes of patients. It's not so all black or white. Yes, you are right. And in the second of the model, yeah, the septos. I am not destroying all the background of the investigators that use the streptozotocin model, but I only to make a reflection that when we are looking at the very early effects of neurodegeneration, we have to take into account the neurotoxic effect of streptozotocin itself. Of course, at very more later examination, this effect disappears and then all the results are valid. But when you're looking at the mice at 1 week after the administration of streptozotocin, I think that it's very difficult to know what is the reason of the neurodegeneration. So it's only an attention for the.
So what are the inclusion criteria for your clinical trials? What stage of diabetes? And what is your endpoint? What is your primary endpoint?
Well, this is a very nice question. That's the question by which we are not progressing in, as you know, in new treatments for diabetic retinopathy is because there are at least 5 years of follow-up are necessary. And also you need a lot of patients in all the arms. So there are not big industry that could support the economic to fund this because it's very, very difficult. So only, and then the European Commission are very interested in surrogate endpoints that predict the hard points of ETDRS accepted progression of 2 or 3 steps of visual acuity. And this, among these surrogates will be the OCT and multifocal electroretinogram of microperimetry or other measurements of neurodegeneration. And the big thing that we have to answer in this IMI2 call is whether or not these surrogates could or not be able to substitute the hard endpoints till now. So it's crucial in order to obtain at the end more funds for investigating new treatments. Because if the problem with somatostatin, for instance, if we finally found that it's useful for reducing neurodegeneration, the regulatory can say, well, and visual acuity? Have you reduced visual acuity? I don't know. So, well, it's not useful for diabetic retinopathy. Wow, this is absolutely without sense nowadays, I think. So we need new surrogates.
So one last question.
Hi, this is Daniel from Zurich, Switzerland, Barthelmess. Just a question regarding your methodology. You're talking about early neurodegeneration diabetes, but when you take a close look and use microscopic slides, to detect changes. Wouldn't it be fair also to look at this level at vascular changes and not only say we don't have leakage in the angiogram, because there may be parasite loss. We know that there is data that at already 16-week old diabetic mice, the Akita mice, there is a change in the endothelial renewal, so that could have also an effect. So
Yeah.
I think I was just wondering if you apply the same methods to say it's really neurodegeneration and not the microvasculopathy.
Very, very good question. So in order here you're talking about the neurovascular unit impairment, in fact. And you are right that however, when I presented the slides on neurodegeneration, we have, of course, explored the vessels of the BDB mice. And we have all found in some slides, in some cuts, a leakage of albumin in one of these cuts. So, but the abundance of glial activation and neuron death was absolutely more important than the only little leakage of albumin. But you are right that perhaps we need to sophisticate the examination of vascular impairment. So if we are using, for instance, flickering, that is integrating endothelial reactivity and by nitric oxide and neuron mediators, we found very early that the flickering is impaired in diabetic retinopathy. So in fact, is no, as previously mentioned, is not all neurodegeneration, not all microvascular disease. I would like to provoke you. And it's the both, and for these reasons has been called, coined the term impairment of neurovascular unit, because you and me are comfortable in this wording.